Assalamualaikum and good morning to one and all. Today we'll start with new chapter that is therapeutic drug monitoring. It is also called as the TDM. I am Professor Sheikh Abu Sufyan. Welcome you to my YouTube channel Pharma Learning. At the end of this e-learning session, you are able to define TDM, explain criteria and indication of the TDM, and justify why TDM is needed in case of digitalis and phenytoin. Let's see the definition of TDM, that is therapeutic drug monitoring. So basically the TDM, it is a measurement or interpretation of drug, blood or plasma drug concentration. So what you are measuring? You are measuring the blood or plasma drug concentration with two important purposes. First purpose is to optimize a patient drug therapy. So why you are measuring the drug, blood or plasma drug concentration? So your first purpose must be optimizing a patient drug therapy and their clinical outcome. So you want to optimize patient drug therapy and the clinical outcome should be more. So in order to get the more clinical outcome, you precisely measuring the plasma drug concentration of that particular patient. Okay. So if in case suppose you have not getting the optimum plasma drug concentration, then accordingly you can adjust the drug. Either if it is giving the more concentration that may lead to toxic effect, then you can reduce the concentration. Likewise, if you get the concentration which is below therapeutic range and it is not producing the good expected pharmacological effect, then in that case you can increase the dose of drug. So this is how, by measuring and interpreting the blood and plasma drug concentration, you can optimize a patient drug therapy and clinical outcome. So this is first purpose. Second purpose is to minimize the risk of drug induced toxicity. There are few drugs like digoxin, phenytoin, right, warfarin. These are the drugs which having very narrow therapeutic index, and in such case slight increase in a concentration of the drug, it may produce toxic effect. So on time, if you can measure plasma drug concentration, so you can predict now it is in the steady state plasma concentration range. If that is the case, then don't increase the dose, right? If you increase the dose, it may increase the risk of drug induced toxicity. So with the help of measuring or interpreting the drug, plasma and blood concentration, what you are measuring is you obtain or you target to get or to achieve two important purposes. First, it is optimizing patient drug therapy and clinical outcome, and second is you minimize the risk of drug induced toxicity. Okay, so this is all about the definition of the TDM. Now we'll see what are the criteria and indication of therapeutic drug monitoring. Now try to understand first what is difference between the criteria and the indication. So you must remember, whenever we are talking with reference to the drug, so the criteria is whenever I discuss with reference to the drug, then in such cases that is called as criteria of therapeutic drug monitoring. In other words, which drug need therapeutic drug monitoring, it is decided by certain criteria. Okay. So let's see which are those criteria, and after this we'll see the different indication of therapeutic drug monitoring. So the drug which need therapeutic drug monitoring, so the first and very important criteria is the drug should have narrow therapeutic index. So if drug has narrow therapeutic index, then it is one of the ideal drug which need or which concentration needs to be monitored by process of the TDM. Because why you need to measure it? Because there is small change in the dose, it may lead to two effects. So one effect may be the loss of efficacy. Suppose if this is the graph of their response and their different time interval, and if this is just therapeutic range which having the narrow therapeutic range, likewise you having another drug which having the wide therapeutic range. So here if you can see, slight decrease in a concentration may not reduces their efficacy, but in such case slight increase in a concentration, now you can see what is happening, there could be possibility of increase in a concentration beyond maximum range, and there could be possibility of going concentration of the drug below normal range. So whenever there is drug concentration goes below normal range, because drug having the narrow therapeutic index, then in that case it may lead to loss of the efficacy, right? So if dose it is lowered or it is just slightly lower, then in that case also there is loss of efficacy. So this is the problem, and to solve this you need to measure the blood concentration. Okay, likewise if there is slight increase in a dose, now suppose if there is slight increase in a dose, then now what happened due to slight increase in a dose, now you can see the drug concentration, it goes beyond the maximum effective concentration, that is called as the MEC. And when concentration of drug goes beyond MEC or maximum effective concentration, that drug will start showing the toxicity, or that drug will show the toxic effect, right? So this is the reason why drug with narrow therapeutic index need to be monitored by using the principle of the TDM. Let's see a few example of this drug. The important drug, it is the digoxin. So digoxin, it is cardiotonic drug, but it should be compulsorily monitored by the measuring their plasma concentration. Likewise theophylline, or likewise the lithium and the phenytoin. These are well-known drugs which need to be monitored by the TDM. Why you are monitoring by TDM? Because these are the drugs with narrow therapeutic index. So the first criteria, which is the drug with narrow therapeutic index. Let's see the second criteria. So the second criteria is when drug having non-linear pharmacokinetics. So very good example in case of phenytoin. In phenytoin, it having various reasons why it need TDM, right? So one of the reason it is the drug phenytoin, it having non-linear pharmacokinetics. Now very interestingly, when you plot the dose and response of the drug, and you get certain level of the curve, okay? And when you see their therapeutic range, the therapeutic range is also narrow. So it is observed that in some patient, due to the non-linear pharmacokinetic, the phenytoin concentration doesn't remains within this therapeutic range. Sometimes what happens, in some patient, the concentration of phenytoin, it is observed that at therapeutic dose, it is going beyond therapeutic range, and the phenytoin doesn't able to control the seizure. And those patients, in spite of taking phenytoin, they will suffer from uncontrolled seizure. Likewise, it is in other patient, what happens, it is just exactly reverse. Instead of the concentration of the phenytoin within therapeutic range, it goes beyond therapeutic range, and now that patient will start showing adverse effects which are related to the phenytoin. So this could be the possibility, because the phenytoin, it is their pharmacokinetic, it is unpredictable, and it is changed from patient to patient. Okay, so this is the reason why phenytoin need TDM or therapeutic drug monitoring. So it has potentially clinically important interaction. Phenytoin is interact with many drugs, and due to the interaction with many drugs, their concentration may change. So this is another reason. Likewise, it is also associated with the large pharmacokinetic variation between the individual. Means that is what I have discussed, that if you are giving phenytoin at therapeutic dose through different people, then you may see different rate of absorption in those people. Why it is happening? Because it is associated with large pharmacokinetic variation between the individual patient. So these are all reasons why those drugs with non-linear pharmacokinetics, so just we have seen one example, likewise many examples are there, need to be monitored by therapeutic drug monitoring. So we have seen the second criteria, drug having non-linear pharmacokinetics. Okay. The third criteria, it is when the beneficial concentration response relationship, it is exist between the blood drug concentration and their pharmacological effect. Now, if when you give the drug to the patient, and if it is observed that it produce the optimum effect at certain concentration. So if it having certain concentration in the blood, and that concentration, patients start showing very good optimum effect. If that is the case, what you can do, you can measure plasma concentration of the patient. Once the plasma concentration, it reached to the level where patients start showing optimum effect. Now you can maintain that concentration continuously so that you can get the beneficial relationship between the concentration of the drug and their pharmacological effect. So there are some few drugs which where you keep on titrating the dose, you measure plasma concentration, you correlate with their response, and when you get the optimum response, you maintain the concentration of the drug in between that particular range. Okay, so this is the third criteria with the drug. So the preferably with respect to both clinical efficacy as well as the toxicity, means drug produces good clinical efficacy as well as produces the less toxicity, right? So you need to maintain the concentration within particular range. Okay, so we have seen the third criteria of the TDM, in which drug need TDM with the drug with a good relationship between the concentration response relation concentration and their pharmacological effect, right? Likewise, the fourth criteria, it is in case of drug when there is no other easily measurable physiological parameter it is exists, like blood pressure. So now if you want to see the effectiveness of antihypertensive drug, obviously what you are monitoring the blood pressure of the patient, isn't it? So if blood pressure it is in the normal range, that indicate that the antihypertensive drug start showing their pharmacological effect. They are showing their desired pharmacological effect, right? Now, in case if there is drug where there is no measurable physiological parameter is there. Let's see one more example. In case of anti-diabetic drug, how you will come to know that anti-diabetic drugs are effective? Obviously, you simply measure blood glucose level. If blood glucose level within it is coming down to the normal range, that indicate that your anti-diabetic drugs produces anti-diabetic action, right? Now if you are giving some another drug, for example, you are giving the drug for the treatment of the constipation, so in such case there is no measurable physiological parameter. You are giving the drug for say thinning of the blood, anticoagulant, so direct measuring parameter is not there. Other parameters are there, like blood clotting you can measure, clotting time you can measure, so those could be the parameter, right? But better option it is, instead of that you can just measure the plasma concentration of drug, because there is no measurable physiological parameter it is exist in those case of the drug. So this is the fourth criteria for the drug which need to be monitored by therapeutic drug monitoring. So we have seen the criteria for the drug which is monitored by therapeutic drug monitoring, and we have seen there are total 4 criteria. Now let's see when should go for the TDM, right? And that is also called as appropriate indication for therapeutic drug monitoring. So when we have discussed about the criteria it is related to the drug. So don't get confused, because sometime in exam they ask question on the criteria of the TDM, and if you confuse you write about the indication, and sometimes they ask question about the indication of the TDM. So when I say criteria, it means I am talking with reference to the drug. So which drug need the therapeutic drug monitoring? And when I say indication, it means I am talking with reference to the patient. Which patients need to be monitored by therapeutic drug monitoring? Got it? So the criteria it is related to the drug. Okay, so which drug need to be monitored by the TDM, and the indication it is something which is related to the patient. Which patient need therapeutic drug monitoring? Okay, so let's see appropriate indication for the TDM. So first it include the patient with inadequate clinical response. Now you are giving drug to the patient, and in spite of the drug therapy the patient showing inadequate clinical response. So that what that indicate? So before switching over to the another drug, you first see and measure their plasma concentration. It quite happen that the therapeutic dose that you have given to that patient, it is not reaching into the blood, and it may not be bioavailable due to different factors. So you can identify those factors later, but first you can measure what is plasma concentration of the drug. If that concentration, if it is not in the therapeutic range, what that indicate? It indicate that you need to slightly increase the dose of the drug. Okay, so let's see among this in which patient this could be possible. So the example it is in case of the transplant patient. So in transplant patient, you are giving the cyclosporine. So why you are giving cyclosporine? This in transplant patient, if when organ it is transplanted, your body try to reject this transplant through the immune system. So what you are doing, you are giving immunosuppression drug. So cyclosporine it is one of the immunosuppression drug. So if you are not giving immunosuppressant drug, then it's quite possible that the body may reject that transplant. Suppose the kidney is transplanted, then body himself will produce the antibody against the kidney and produces the damage to that newly transplanted kidney. So what you are doing in order to acclimatize that kidney into the body, till the time it is not getting acclimatized, you are giving immunosuppressant drug. So example it is cyclosporine. So sometime you give the cyclosporine, but in spite of that there is the organ rejection. So to avoid that, or to avoid the risk of organ rejection, what you can do, you can measure the concentration of the cyclosporine in the plasma. Okay, so you can reduce the risk of the transplant rejection. So this is the first indication. So patient with the transplantation or unusual clinical response. The second thing, it is again the patient. So as I have mentioned, when I am talking about indication, we are talking with reference to the patient. So second, it is in the patient with the sign and symptom of the drug toxicity. So example, in case of patient suffering from nausea with the theophylline. So theophylline, it is the bronchodilator drug, and patient on the treatment with the bronchodilator drug like theophylline suffering from the asthma, and when he take the theophylline, he suffer from persistent nausea. So the nausea or to the theophylline, it indicates that the dose or the concentration of theophylline in the blood, it is reaching to the toxic level. So whenever such any sign and symptom of drug is there which is related to the toxicity, you must monitor that drug, or in that patient you can measure the plasma concentration of the drug. Okay, so I have just taken the example of theophylline. Likewise, many toxic effect, if it is observed in the patient, in that case, the patient it is on treatment with particular drug, their plasma concentration you can measure. Okay, third thing. Okay, so before that we'll see why we are doing this, because we are doing this to minimize the risk of drug toxicity. Example, in case of the nephrotoxicity and ototoxicity which is associated with the aminoglycoside, right? So this is another example. So first example we have seen in case of theophylline. So the patient show the nausea, whereas in case of aminoglycoside, patients show very severe effect like kidney failure. It produces the effect on the kidney, right? So that is very dangerous. So in such case, you can minimize the risk of drug toxicity by measuring the plasma concentration of all those drugs which having the risk of more toxic effect. Okay, so this is the second indication. Third indication is to individualize dosing for the drug, because dose of the drug, it is not necessary it should be same for every patient, right? So you because patient having different physiology, so the patient dose which may show the drug dose which may show good effect in one patient, it is not necessary that at the same dose it will produce same effect in the another patient. Okay, so to individualize dosing for the drug, you can do the TDM, right? So especially in case of the dose drug where there is unpredictable dose response curve, and we have seen in case of the phenytoin there is non-linear pharmacokinetics. So the dose response curve, it is very unpredictable. So sometimes the dose response curve is something like this, okay, and sometimes the dose response curve, if you measure in case of the phenytoin, it is going something like this. Okay, sometimes it is flat, sometimes it is going in a sigmoidal way, right? And sometimes it show the steady state concentration, and sometimes it show the wide change in the concentration of the drug. If that is the case, then that drug should be monitored by therapeutic drug monitoring, right? So in those patients, if you see there is the non-linear pharmacokinetics and all those parameters are there, so to individualize dosing for the drug in that particular patient, you can do the therapeutic drug monitoring. So let's see what you can do by individualizing. So the individualizing through TDM, it helps you to predict the patient dose requirement. What is exact dose it is needed to that particular patient will be come to know to use. So what you will doing, you measure plasma concentration, you measure the response, right? And when the beneficial relationship you see between plasma concentration and the response, you now select that dose for that particular patient. So with the help of measurement of plasma concentration of the drug and measurement of the response, you can predict a patient dose requirement, and you can identify what exact dose, beneficial dose it is needed to that particular patient. So this is also called as the individualization. Likewise, you can individualize rapid dose titration while minimizing the risk of the toxicity. Right? When you measure the plasma concentration, you based on that you can guess that at what dose there could be the possibility of the toxicity. At what dose there could be the possibility of optimum effect. So when this, it will come to when you will take this decision, or when you can interpret this, when you measure the plasma concentration and when you measure the response. When you see the toxic effect, the moment you see the toxic effect or any sign and symptom of toxic effect, you should not give that dose. So all the doses must be below the dose which show the toxic effect. Got it? So this is how you can individualize and rather titrate the dose while minimizing the risk of the toxicity. It also helps you to assess the medication compliance. Sometimes what happens, patient says that he took the medicine, right? But due to the bad taste of the medicine, and sometimes some patients are they are not comfortable with taking the medicine. So what they are doing, they just take out medicine from the strip and they throw it into the dustbin, right? So when you see and when you do the residual counting that you generally do to measure the patient non-compliance, you see that patient has already consumed the medicine. The record show that patient has consumed the medicine, right? Then why does seizures are not controlling? Isn't it? So this is the question. So how you can solve this problem? You can simply measure plasma concentration. So if drug it is there in the plasma or the blood, that indicate that the patient has consumed the medicine. If that is not the case, it means the patient has thrown the medicine in the dustbin. Got it? So in such case also you can do, especially in case of the drug which are very important in controlling some serious diseases like the epilepsy, seizure, and many other diseases like the heart attack. So you are giving the warfarin, aspirin. So in such cases, those drug can be in those patients. You can monitor the plasma concentration of the drug. Okay, so I'm talking about the patient. So third indication we have seen, that is in case of the individualization of the dose, okay, or the individualization of the pharmacotherapy in the patient. Fourth indication, it is when the patient has consumed the poison. Okay, so you are measuring the plasma concentration not just to measure the concentration of the drug, but also to identify which poison is consumed by the patient. Suppose patient brought to the hospital, and when he brought to the hospital he is unconscious. So when he is conscious, you can ask him the question and you will get idea what he has consumed. But when he is not conscious, how he can tell you that what he has consumed unless someone has seen that, right? So if this is the case, then simply what you can do, you can take the blood sample and try to identify that particular poison, and you can assess the severity of poisoning. So very importantly, in case of paracetamol poisoning, you can measure the metabolite of the paracetamol which is responsible for the toxicity. So N-acetyl parabenzoquinine, it is the metabolite of the paracetamol which is responsible for the liver toxicity. So instead of measuring the concentration of the paracetamol, you can simply measure the concentration of that metabolite which is responsible for the toxic effect. Okay, so paracetamol poisoning you can identify with the help of measuring plasma concentration of drug. Likewise, you can also measure the plasma concentration to ensure the effectiveness of the antidote and help or any drug which help in the excretion of the poison. So the effectiveness of both antidote and the excretion of the poison can also be monitored by measuring the concentration of that drug or the metabolite. So with the help of this, you can control the patient condition by just monitoring or by measuring the concentration of the poison, and accordingly you can decide what strategy can be adopted to control the condition of that individual patient. Okay. So we have seen about the indication. So we have seen 4 criteria and 4 indication for therapeutic drug monitoring. Now we'll see the TDM in case of 2 important drugs, and this is very favorite question of the examiner. That is, justify why TDM it is required for digoxin and why TDM it is required in case of the phenytoin. So let's see the reason. The why digoxin whenever treatment is given, or it is compulsory rather to monitor the plasma concentration of the digoxin. So let's see the reason. So do remember that the digoxin it is used in case of 2 clinical condition. First clinical condition, you are using it in case of the heart failure, and in case of heart failure the dose of digoxin it is between 0.6 to 1 nanomole per liter. Now clinical condition it is the heart failure, and what is the dose? Dose it is in the range of 0.6 to 1 nanomole per liter. Whereas in case of arterial failure, which is very dangerous because arteries are major organs, they are responsible for pumping the blood in the heart. So if that is the case, if there is arterial failure, then you need the dose between 0.6 to 2.6 nanomole per liter. So looking at dose, the dose is very less and the dose range is also very narrow. So now in case of heart failure, if the dose drug if it is given instead of between 0.6 to 1, suppose you are given 1.7 nanomole, right? So there is increase in a dose that is absolutely not needed in case of the heart failure. So these dose may produce the cardiotoxicity, isn't it? Likewise, if dose come beyond 0.6 range, it may not able to protect you from the heart failures because this is something which is serious illness. So whenever you are dealing with the serious patient, which is where the major organ like heart it is affected, then that drug to be monitored by therapeutic drug index. Now, if you just look at the concentration, the range or the dose range which is needed, then in case of heart failure there is just difference of the 0.4, and that is also nanomole, not even the micromole. It is just nanomole per liter, isn't it? So there is only difference of 0.4 nanomole, and it is quite possible that the concentration of the digoxin may come below the 0.4 as well as above the 0.4 range, right? So what is this? This is called as drug with very narrow therapeutic index. So since it having the narrow therapeutic index, the digoxin need to be monitored by therapeutic drug monitoring process. Second reason, if you see the half-life of the digoxin half-life it is between 30 to 50 hours, which may since it having the wide range of half-life, it's not like only 20 hours, right? Only between 20 to 22 hours, only difference of 2 hours may be there in individual patient. But if you look at the half-life of the digoxin, it changes from patient to patient between the range of 30 to 50 hours, right? It means some patient they take 50 hours to remove the 50% of digoxin from the body through the excretion, and some patient they just take 30 minutes to remove 50% of the drug or the digoxin from the body, isn't it? Since there is wide variation in half-life is there, you cannot predict exactly how much amount of digoxin it is excreted from the body. So always there is a risk of cumulative toxicity, it is there in case of digoxin. So better whenever you are giving treatment with the digoxin, you measure their plasma concentration and accordingly you decide what could be subsequent dose to be given to the particular patient. So the second reason in case of the digoxin where it needs TDM, it is half-life, it is in the wide range of 30 to 50 hours. So it increases the risk of cumulative toxicity, which mandate the physician to conduct the TDM process in case of the digoxin. Third reason, in case of low serum potassium level, and low serum potassium level, it is generally seen in case of the diuretic treatment. The diuretic patient, they suffer from the hypokalemia, right? If that is the case, you have seen in case of the drug interaction, what it does, it potentiates the toxicity despite serum digoxin concentration, it is within therapeutic index. So when you are measuring the concentration of digoxin, you need to also measure what is the concentration of the potassium, because if concentration of potassium if it is low, if patients suffer from hypokalemia, although digoxin concentration it is within therapeutic range, but still patient will suffer from the toxic effect. Got it? And toxic effect of digoxin, it is very dangerous. It produces the cardiac arrest. So instead of cardiotonic effect, it produces the cardiac arrest. Okay, so you will be measuring the potassium concentration and you will be also measuring the digoxin concentration. I hope you got the idea why we are doing that. So that is the third reason. Fourth reason it is the plasma concentration may be elevated by different drug. Now suppose the patient is on treatment with the amiodarine and he is also taking the digoxin. So the level of digoxin will be increased by the amiodarine. Likewise, patient on the treatment with the antiarrhythmic drug like the quinidine, verapamil, which is anti-hypertensive drug, likewise diltiazem. So these are all drugs which increases the level of the digoxin. So you have to be very careful about what drug to be selected in the combination with the digoxin. It should not affect their concentration. And if at all, if you are giving those drugs, then simple option is to monitor the plasma concentration of digoxin, and accordingly you can decide what subsequent dose to be given in that particular patient. Okay, so these are important four reasons we state that why TDM it is necessary in case of the digoxin. Okay, next drug it is the phenytoin. So let's see why TDM it is required for phenytoin. So again, therapeutic range for the anticonvulsant therapy of the phenytoin, it is in between 10 to 20 milligram per liter. So the dose range, it is very narrow. It is just between 10 to 20 milligram per liter. So obviously the first reason of the phenytoin, rather that is the first criteria of the TDM, that is narrow therapeutic index. Second thing is that again in case of the phenytoin, the adult half-life, it is in between 10 to 30 hours. So wide range is there. Some patient they are having half-life of 10 hours. Some patient they show the half-life of 20 hours. Some patient they show half-life of the phenytoin of the 30 hours. So there is wide range, and obviously if that is the case, it increases the possibility of cumulative toxicity. So the second criteria, which is similar to your digoxin, it also there in case of the phenytoin. Third important criteria that we have seen, it is the plasma concentration of the phenytoin. It may be elevated by different drug like amiodarine, azole antifungal drug, cimetidines, diltiazem and fluoxetine. So we have seen this amiodarine and diltiazem. It was also common in case of the digitalis. So it is also common in case of the phenytoin. So these drugs, they increases the plasma concentration of phenytoin, right? And if slight increase in concentration of phenytoin is there, it may lead to severe toxicity. If decrease in level of phenytoin is there, patient may suffer from uncontrolled seizure. Their seizure will not control, right? So that is the problem where why you need to monitor the phenytoin by the TDM. Then we have already seen the reason. The small increase in a dose give disproportionate increase in a plasma concentration. So what was the problem? Non-linear pharmacokinetics. So phenytoin, it is well known for non-linear pharmacokinetics. So better to see their own plasma concentration at particular time. Likewise, the very dangerous thing, it is seen in case of patient with hypoalbuminemia and severe renal failure, because the phenytoin, it is excreted by the kidney, and 99% of the phenytoin, it remains in bound form to the albumin. Now if the level of albumin goes down, then what will happen? Instead of 99%, depending upon amount of albumin proteins are there, that may much amount of drug only bind to the albumin, remaining it is in the free form, and this free form of the drug will increases the plasma concentration and it produces very severe toxicity. Likewise, if the patient suffering from the nephrotoxicity or kidney disease, then phenytoin will not excreted and it may lead to cumulative toxicity, and patients start showing very severe side effect to the phenytoin. Okay, so what you can do, you can measure the free concentration of the drug, because free concentration of drug, it is more in case of hypoalbuminemia as well as renal failure. So you can titrate the dose to the lower range so that the dose that you are given, it does not show the adverse effect in the patient. So I have done with my today's session. We have seen why TDM it is needed for the phenytoin. We have also seen why TDM it is needed in case of digoxin. We have seen the 4 criteria for the TDM, which drug need the TDM. Likewise, we have seen the 4 indication for the TDM, which patient need to be monitored by the therapeutic drug monitoring. So I must thanks to the author of this textbook. So I am for most of your chapter of the clinical pharmacy, I am referring this book, that is Dr. H.P. Tipnis and Dr. Amrita Bajaj. They have given wonderful information on the clinical pharmacy. So thank you very much for watching my session. For more such learning, subscribe to my channel, and if you like my session, then do remember to give me a thumbs up.